What are blackouts? Blackouts are transient, spontaneous loss of consciousness followed by complete recovery. Blackout is a common symptom. 1 in 2 people will experience a blackout at some point in their life. Thank you for stopping by this video. If you're new to this channel, hi, my name is Dr. Erwin Kwun. I'm on a mission to help doctors lead a happier and fulfilled life. I make new videos every Thursday on the subject of GP training, well-being, and high performance. Every Thursday I publish a new video. Make sure you subscribe to this channel so you don't miss any future videos. And don't forget to ring the bell so you're notified first each time I publish a new video. The most common underlying cause of blackout is due to vasovagal syncope. Vasovagal syncope is usually accompanied by the presence of features suggestive of uncomplicated faint. The 3 P's: posture, blackout occurring after prolonged standing. To assume an upward posture, the body needs to work against gravity to maintain blood supply to the brain. This is done by tightening the blood vessels. After prolonged standing, the reflex that keeps blood supply to the brain reduces. The next P is provoking factors. This includes fear, pain, or a medical procedure. The last P is for prodromal symptoms. Patients may have warning signs such as clamminess, sweating, or feeling warm, hot before the blackout. A good account of the event is vital to diagnose the cause of blackouts. Seek to get a collateral history from a witness if possible. Asking a witness to recount the blackout will help you to understand the cause of the blackout. Ask about the circumstances of the event. It is helpful to think about pre, peri, and post-event. In the pre-event, you want to know what was the person doing before the blackout. Did the person have any warning signs? Some people describe their vision zooming out, buzzing in the ear just before they have the blackout. In the peri-event, you want to know the duration of the loss of consciousness. Did it last for a few seconds or fraction of a second? Was there any jerking of the limbs, or did the person lose their color? This is where collateral history from a witness would be valuable. It is difficult to establish the duration of loss of consciousness if a blackout is unwitnessed. Post-event, you want to ask about any confusion, any lethargy, whether the person remember what happened. Suspect epilepsy as an underlying cause if the presence of tongue biting, loss of bowel and bladder control, prolonged limb jerking, confusion following the event. Ask the patient about associated symptoms such as chest pain, any visual disturbance, any aura, palpitation. Ask about any nausea and vomiting or any fever. Explore the patient's past medical history, whether the patient had any personal history of heart problem, valve problem, or rhythm problem. Ask about any previous faints. Explore the patient's family history. Is there any family history of sudden cardiac death? Establish the patient's occupation because this can impact their ability to carry on working. Ask about their driving status. Ask the patient whether they drive and check how they came today. NICE-CKS has published guidelines in assessing blackouts. Assessment of vital signs, for example, pulse rate, rest rate, oxygen saturation, and temperature. You might need to repeat this if indicated. Measure the patient's lying and standing blood pressure. It is important to carry out a cardiovascular and a neurological examination. This includes cardiac auscultation to check for heart murmurs, an assessment of the presence of sensory motor, speech, and vision deficits. A 12-lead ECG is important to investigate for any cardiac arrhythmia. Consider measurement of blood glucose level to check for hypoglycemia if you suspect this. Other blood investigations include a full blood count to check for hemoglobin level if a patient is anemic or you suspect bleeding. The many causes of blackout, these include a neurally mediated reflex syncope, such as vasovagal syncope, fainting, carotid sinus syndrome, and situational syncope. Orthostatic hypertension is when there's a fall in systolic blood pressure of at least 20 mm Hg or at least 30 mm Hg in people with hypertension, and or a fall in diastolic blood pressure of at least 10 mm Hg within 3 minutes of standing. Blackout could be caused by cardiac abnormalities. These include bradycardia, tachycardia or low cardiac output, blood flow obstruction, vasodilatation, or acute vascular dissection. Other causes of blackout include endocrine and metabolic cause such as severe hypoglycemia, hypocalcemia, drug and alcohol use. Epileptic seizures can also cause blackouts. The management of blackouts depend on the underlying cause. NICE seekers recommend if the underlying cause for blackout is uncomplicated vasovagal syncope or situational syncope, and there are no features to raise clinical or social concerns, explain the mechanisms causing the syncope to the patient, advise on possible trigger events and strategies for avoiding them. If the trigger events are unclear, advise patient to keep a record for the symptoms when they occur and what they were doing at the time in order to understand what causes them to faint. Reassure patient that the prognosis is good. For patient with suspected vasovagal syncope with recurrent episodes of blackout, which is adversely affecting their quality of life or representing a high risk of injury, consider offering referral for a tilt test to assess whether the syncope is accompanied by a severe cardio-inhibitory response, usually asystole. Life-threatening causes of blackout such as myocardial infarction and ischemia, cardiac arrhythmia or occult hemorrhage warrant immediate hospitalization for further assessment. Consider ectopic pregnancy in a woman of childbearing age as a cause of blackout. If you suspect orthostatic cause of blackout, review drug therapy and eliminate any potentially causative drugs where possible. Advise simple lifestyle changes to treat orthostatic hypotension. These include drinking at least 2 liters of water a day, increase salt intake if the patient doesn't suffer with hypertension, avoid alcohol consumption. If you suspect a cardiovascular cause and a patient doesn't require admission, consider an urgent referral for cardiovascular assessment. Advise patient to seek urgent medical attention if symptoms recur. Advise patient to refrain from physical exertion if appropriate. If you suspect epilepsy as an underlying cause, referral to neurological assessment is warranted. Advise patient to seek urgent medical attention if symptoms recur. Advise patient to avoid swimming and take care when bathing to avoid the risk of drowning. Advise all people who have experienced a blackout that they must not drive while waiting for a specialist assessment. Consider arranging a follow-up appointment with a patient while waiting for referral or if symptoms don't improve with treatment. Thank you for staying until the end of this video. If you found this video useful, I've got another video I want you to watch. I'm sure you get something out of it if you flagged this video. This is where I break down how to assess and manage dizziness. Click on the video to learn more about how to assess and manage dizziness. As always, make sure that you subscribe if you're not already subscribed and turn on notification bell. Take care everybody. Bye bye.